thank Dr. Manish for making me a part of this wonderful IC. Glaucoma, it is defined as a optic neuropathy, and hence optic nerve evaluation is central to the diagnosis of glaucoma. Binocular examination is the way to go, and it's best done with a slit lamp and a lens, and most of us have adapted to this method of examination. For beginners, start with a dilated pupil, a coaxial eyepiece and illumination, a slit which is neither too wide nor too narrow, and while examining the right eye of the patient, ask him to look at your right ear. Basically the eye has to look slightly nasally. Once you do that, take the slit as far as possible from the eye, hold the lens 3/4 inch away from 3/4 inch away from the eye, and now start moving the assembly towards the eye, and the optic nerve will come into view. Now, what are the features that you need to examine in a disc? So, disc size and shape, cup disc ratio, neuroretinal rim configuration, color, and additional features, as we will see. These are the 5 things that you need to look into. Now, first, identify the disc margin. Sometimes the disc margin can be fuzzy, as in this case, and you need to make a note of the same. Next, assess the disc size and shape. After that, identify the cup border. Having done this, now gauge the cup disc ratio. Remember, cup disc ratio is just one method of describing the disc, and in isolation means nothing. Judge the disc size. Irrespective of the disc size, 1 million neurons will pass through the optic nerve, and hence a larger disc will have a larger cup, and hence a larger cup disc ratio. If you see here, this is a large disc with CD 0.7 to 0.8, and here it's 0.2, and here it's a full disc. Physiological cupping is the epithet given to a large disc with a large cup disc ratio. Now, the visual impression of a large CD ratio makes it more susceptible to be labeled as a glaucomatous disc, and similarly damage is likely to be missed in a disc like this, which has no cup. Between the rim and the cup now lies the neuroretinal rim. The real substance of the disc lies here. In this disc, it's very easy to trace it 360 degrees. But in some discs, it may not be possible, and that's when the deflection of the blood vessels will give you a clue as to where the cup ends and the neuroretinal rim begins. In most discs, the inferior neuroretinal rim is the thickest, followed by the superior, then the nasal, and then the temporal, and this is what is the famous Isn's rule. Progressive destruction of the neuroretinal rim, particularly in the superotemporal and the in the inferotemporal regions, is pathognomonic of glaucomatous damage. When there is complete destruction of the neuroretinal rim, it is called a notch, and when there is partial destruction, it is called thinning. This asymmetric neuroretinal rim loss is called reflex in the form of violation of Isn's rule. This is one more example where the superotemporal rim is completely destroyed, and this is also reflected as violation of Isn's rule. Now, these are two discs. Even in discs which are different, Isn's rule may not be followed, but if you trace the neuroretinal rim, you will be able to recognize focal destruction. These are two tilted discs of two different people. One to the left shows a healthy disc. It's a tilted disc, but it's a healthy disc, but hardly any cup. But if you see this particular disc, if you trace the neuroretinal rim, you will realize there is an inferior notch, and sure enough, the fields showed a superior arcuate scotoma. In certain discs, the notches cannot be shown very well in a photograph, but they can be seen very well in the on the slit lamp. Now, this is one example where there is an inferior notch, but it is completely masked by the blood vessel. But the deflection of the blood vessel will give you a clue, but if you are not careful, even on a slit lamp, you may miss this kind of a early notch. Having identified the configuration of the neuroretinal rim, now let us go to the color. Most of the times a healthy disc has a nice reddish tinge, but the neuroretinal rim is not uniformly colored even in healthy eyes. Typically, neuroretinal rim destruction precedes pallor, and hence it is said that cupping is more than pallor in a glaucomatous disc, and the reverse is true in a non-glaucomatous disc. So, this is one disc where the patient had a sphenoidal rid meningioma which caused the optic atrophy, and this is a disc which typically shows pallor more than cupping. One exception to cupping is more than pallor in a glaucomatous disc is when there is reversal of cupping after reduction of intraocular pressure, especially after surgery, where the cup fills up. It is filled with glial tissue, but the pallor remains, and here in this case you will find that the pallor is more than cupping, but it is still a glaucomatous disc. Symmetry between the discs of the two eyes is an important part of evaluation, and and a difference of more than 0.2 has to be looked into more carefully. Now, the other features are like disc hemorrhage, peripapillary chorioretinal atrophy, a bearing of the circumlinear vessel. These are not pathognomonic, but in case of a suspicious disc, they may tilt the balance and help you diagnose better. Nerve fiber layer examination is an extension of a disc examination, and very subtle, and they are best seen on a photograph. Now, here in this particular disc, you have a notch in the disc and a corresponding nerve fiber layer defect. But if you do not take a disc photograph, you will miss the very subtle nerve fiber layer defect which is superiorly, and hence I have been a strong advocate of a disc photograph whenever you have a suspicious disc. Now, I had always believed that if there is a nerve fiber layer defect, it will reflect onto the disc, but of late that belief has changed, and if you see this particular disc, there is a very subtle nerve fiber layer defect which I will completely miss on a slit lamp when I am examining the disc, but is seen well here, and the disc does not show any change, and all nerve fiber layer defects are not glaucomatous, but this was in a patient whose father has lost one eye due to glaucoma. So, it is more likely to be glaucomatous. Now, disc coloboma, like congenital anomalies of the disc, can be confusing and can be mistaken for glaucomatous disc, like a disc coloboma, congenital pit of the optic nerve, coloboma with an optic nerve pit. Documenting and describing the disc is also a part of an examination. Every disc cannot be photographed, but every disc has to be drawn and described, and these are just different methods of how you can describe a disc even when it is a little different. Features in my experience which people confuse whether is this disc glaucomatous or no, it is a large cup disc ratio, tilted discs, sloping rim, deep punched out cups, laminal dots. People start thinking, oh, is this glaucomatous? Now, a parting tip is, you mentally categorize discs into obviously normal, obviously glaucomatous, suspicious discs and different discs, and in suspicious discs fields and OCT might help you decide. So, thank you all for a very patient listening, and Manish, thank you once again for including me in this idea.